Good afternoon to this ninth episode of the Ask Gunshila series, which is a patient educational program. Today, our topic is going to be recurrent miscarriage, and I am Dr. Devika Gunasheela, the director of the Gunshila Group of Hospitals, and with me is my very young and very dynamic colleague and senior consultant, Dr. Nayya, who heads our feto-maternal branch of medicine.
Thank you so much, ma'am. Happy to be with you today.
Great. Now, today we're going to be talking to you about miscarriage, and you can text in your questions at any time during the program, or at any other time, you can write to ask@gunshila.com. Now, a small introduction of miscarriage. First of all, the term miscarriage. It used to be in yesteryears called as abortion. And now abortion has become a term which we no longer use because we think it is insensitive, and the whole world does that. And so abortion is mainly limited to somebody who voluntarily terminates their pregnancy for whatever reason. And a miscarriage is something where it has happened, although the couple wants the pregnancy and somehow has not been able to stop that. So, can you tell me exactly how you would define a miscarriage, Dr. Nayya?
When there is a natural demise of a baby before 20 weeks of gestation, we call it as a miscarriage.
Yeah.
It's one of the most common obstetric complications that we see. It's as common as 1 in every 4 ladies would have experienced a miscarriage. And even before some ladies get to know that they are pregnant, unfortunately, they miscarry the baby. It is extremely devastating when even a single miscarriage occurs, and when if it occurs in a row back to back, then it is a more devastating situation, and we call that recurrent pregnancy loss or recurrent miscarriage.
Yeah, so when you have, there are several definitions of recurrent miscarriage. That means a miscarriage that is happening again and again. And then until some time ago, it used to be three, and then with various different guidelines from different countries, it is now they say that we have to do about two miscarriages. I think that's what we've also written there. We have two miscarriages in a row, and then we would call it recurrent. So really, when somebody has one miscarriage, we really don't have to react so much. We don't have to jump up and down and say, oh, we need to do something, we need to do a panel of tests. Not really, because 1 in 4 miscarry. So it's quite a common occurrence that we see. But then when it happens, twice or the second time also, then we can't say, hello, excuse me, you go back, and then if you again have a miscarriage, then I will treat you. So that's when we actually start to do all our tests. So now we're going to deal with the basic FAQs, and then most frequently asked questions. Why did it happen? What was the reason? What can be done? And so we'll go through these questions one by one. And can you please shed some light on what are the most common causes of miscarriages that happen again and again?
Okay. When pregnancy is miscarried, the most common cause is some genetic problem, some abnormality in the chromosomal makeup of the baby. When the mother's and the father's genes meet up, there tends to be some error, and this results in some genetic problem in the fetus as a whole, and it is lost, unfortunately. That accounts for nearly 40 to 50% of most of the sporadic losses. And sometimes some chromosomal abnormalities in the parents can be carried to the fetus, and it results in recurrent miscarriage. Other common causes are some problems in the structure of your genital organs, that is, some alteration in the shape and the structure of the uterus.
Yeah.
Some maternal medical conditions can predispose a lady to have a miscarriage. Other minor causes like the father's sperm constitution might cause the miscarriage. And
We will come into that
unfortunately,
slowly a little bit later, as in how we go. But then we have a large number of unexplained causes, isn't it?
yes, a large chunk remains unfortunately unanswered.
Unanswered. And also we have this immunological situation where the immunology of pregnancy, that means the pregnancy is basically a graft. It is not completely a woman's genetic material or composition, because the father's component also comes into it. So it is like a graft. So there is a graft versus host rejection that can happen. And so the uterus is a very special organ where it actually covers the fetus, that is the growing embryo or the developing baby, with so many factors that it prevents a rejection. So that is what is extremely special about the uterus. And sometimes when that malfunctions, we come into the realm of immunological disorders,
Yes.
okay, which may produce a miscarriage. So now, according to maternal age, we have, it's just obvious that when you're younger, your eggs are of good quality, and so you will produce good quality embryos and you good quality babies. And this mostly looks at the genetic material of the egg. And as you grow older, the quality of the eggs decreases. So the age is the only one that talks about the quality of the egg. So as you grow older, you can also see that after about 45 years of age, or even after 40 years of age, your miscarriage rate starts to become 51, and it starts to increase. The quality of the eggs that are being produced by the woman starts to deteriorate after the age of 35. Now, you want to tell us about the risk of miscarriage according to the obstetric history?
Yes, ma'am. With each miscarriage, the risk of the next pregnancy ending up in miscarriage also increases. After around 3 miscarriages, the next year chance of miscarriage is up to 40 to 50%. But has a silver lining, there is still 50% chance that you might carry home a nice baby.
Without any intervention at all, just with a lot of, tender loving care and repeated scans and,
Yes,
a lot of positive motivation and things like that. Now, you want to tell us about the gestational age?
Yeah, our patients are behind us to tell us what exactly caused their miscarriage. So we exactly some of the clues that give we do have some clues based on the time at which the baby miscarried. If it is up to 6 weeks, there can be some immunological disorders, like some pre-existing maternal immune problems that can cause the miscarriage. At around 5 to 7 weeks, that is the time when most of the abnormal babies with abnormal chromosomal makeup tend to miscarry. Also, there is a second phase of immunological miscarriages that occur anywhere between 8 to 10 weeks, which is known as alloimmune, when the mother happens to be sensitized to her own baby and produces antibodies to
Against it.
unfortunately destroy the baby.
Yeah.
And also, in the later part of the pregnancy, as we enter the second trimester, certain some problems with the shape and the constitution of the uterus can cause the baby to miscarry. Also, there is a medical condition our recurrent pregnancy loss couples will be familiar, known as the APLA, which can cause miscarriage.
Yeah, see, these are not written in stone. They are some guidelines as to which way we must look at, but can always be interchanged. Immunological causes can cause early pregnancy losses, also very early pregnancies, and so you can have a situation where all these can be interchanged. But these are just the general. We have just classified it like this. Also, you must understand that pregnancy is divided into what we call as trimesters, or 3 parts. Each trimester consists of 13 and 13.5 weeks, not 13.5, but 13 weeks and some 2.5 days or something. So each trimester is 13.5 weeks. So you have the first trimester up to 13 weeks, and then you have the second trimester up to about 26.5 or 27 weeks, and then you have the third trimester. So now going back, now what exactly would we talk about when we talk about genetic causes?
As we have already been discussing, our DNA can be imagined like a large book of large cookbook with full of recipes. This cookbook of our body is known as the DNA, which has a lot of genetic material, and it has recipes to exactly tell what height the person is going to grow up to, what color the
So
person
it basically
is going to.
codes for all our characteristics,
All
isn't
characteristics,
it? Yeah.
physical.
So somebody's tall, somebody's short, somebody's dark, somebody's fair, somebody's got curly hair, blue eyes, red, green eyes, and things like that.
Exactly.
So when you actually have a DNA problem in the parents itself, and the parents may be quite normal by themselves.
Yes, true.
But they can have things like translocations. Do you think?
Yes, ma'am. There is a condition known as balanced translocation
Yeah.
in the parents, which do not produce any symptoms in them, but unfortunately can result in recurrent pregnancy losses.
Yeah.
But luckily for us, the percentage of such miscarriages are quite less, and we will be looking an investigating couple with recurrent miscarriage to see if they have any such problems.
Yeah, whether they're transmitting it to the baby, basically. So now there is a small way that we can actually go about our investigations and trying to come to the cause of why a patient did have a miscarriage. A lot of the times we don't get the causes, and we end up treating patients empirically and on our own clinical, shall we say, judgment and our experience. And other times you do get the causes. So do you briefly want to go into a little bit of an algorithm that we have made? So you look at the POC, we look at the genetics of the products that come out when somebody has a miscarriage, and that will be the fetal genetics.
Yeah, karyotyping.
Yeah.
We see what is exactly the chromosomal makeup of the baby and to see if there was anything wrong, and with that we are able to predict whether such a thing can repeat itself, or was it like an unfortunate accident and it is not likely to repeat. If we find an answer with the products of conception, that is the chromosomal makeup of the baby, then luckily for us, then we will be able to come to a conclusion that it was the problem with the chromosomes, and we need not have to go back searching for other causes of miscarriage. That is one of the options. But we selectively categorize our patients who have to go through this procedure. They go through extensive genetic counseling. We also try to understand if they have had any significant family history, whether they have had a consanguineous marriage, whether the husband and wife are related, and do they have a family history of children being born with problems, do they have stillbirths in their family.
Consanguinity is a very important part, because we have a lot of women and men getting married in the family itself, and it's usually the mamas, that they get married to, or also they will have generations. I've had patients who have had generations of consanguinity. So consanguinity means getting married in the same family to their relatives, and so you can have the grandfather and the grandmother being consanguineous, and then again the parents being consanguineous, and then the couple who's coming to you. So that is quite often produces a lot of problems, at least in the patients that we see. And then so there definitely we should actually look at the karyotyping, and then maybe send them to a genetic counselor and have a look at the rest. But then if there is a huge genetic issue, or if there is balanced translocation, which means that one portion of a chromosome, the total chromosomal content is normal, but then there is a rearrangement in the chromosomal structure. So the patients are okay, but then when they're actually making the babies don't come out very good, and that can lead to a miscarriage. So in those kind of patients, we do have what is called as PGS, it is pre-implantation genetic screening. So now in this, we can actually look at an embryo even before we put it into the uterus, and we can actually decide whether that embryo has a normal genetic structure or not, and then we can go ahead with the putting in the embryo and trying to get a pregnancy for these patients. And we have helped plenty of patients like that. So that is very important genetically, because genetics of the embryo forms a large portion of the contribution to miscarriages. What about the medical conditions in the mothers that produce miscarriages, Nayya?
Yeah, definitely. We have to evaluate the mother to know what is her medical history, because once we catch certain conditions, it is a very fruitful treatment procedure. So that if there is any thyroid disorder, or if they have PCOD, diabetes, hyperprolactinemia, once we can run through a few particular blood tests, specific blood tests, and we get the diagnosis, we could treat them and the outcomes are very fruitful.
Yeah, see, the thing is that especially diabetes and thyroid are very easy to treat. And, and one word of caution is that all women, before they try for a pregnancy, they should actually get, at least one or two tests. One is to see whether especially if they have a family history of diabetes, they should actually look at the diabetic profile in themselves, as well as look at their thyroid, because especially with diabetes, if there's uncontrolled diabetes, invariably it ends in a miscarriage. And also, it's not worthwhile continuing with the pregnancy because the babies can have plenty of congenital defects,
Yeah,
right?
yeah. Unfortunately, though it can be easily picked up and treated, we still have so many patients who are frank diabetes, poorly controlled, and they're coming with recurrent miscarriages. And once in 3 to 6 months, we're able to control their sugars, they are able to carry home a beautiful pregnancy.
Yeah, without much intervention at all.
Without much intervention, much ado about nothing.
Nothing. Yeah, exactly. So, so it is exactly what it says. So once we identify the condition, then we can easily treat them. Like diabetes and thyroid issues can be treated, and also progesterone. Sometimes we have pregnancies that are not very well supported by your own endogenous. Endogenous is whatever is produced in the body by your own progesterone. So we have to give a little bit of progesterone supplementation, and that's all it takes. So again, if you're overweight, diet and exercise. So are now we're coming to the realm of a little bit of infertility over here, infertility medicine, where are repeated miscarriages related to the smaller reserves of eggs in the women. So do you want to tell us a little bit about that?
We sometimes have older women who are coming with they're able to conceive on their own, but they're coming with recurrent miscarriages. And when we happen to evaluate, we see that their egg reserve, which we see is quite less. And these days studies have established that ladies who have very poor egg reserve and they're able to conceive on their own still can be one of the important cause of recurrent miscarriages. And being a tertiary IVF center, we do have certain solutions for these ladies, ma'am.
Yeah. So that comes more into the realm of IVF, and it comes more into poor responders and things like that. So the basic message is here that the older you get, the quality of eggs becomes deteriorates. So the chances of miscarriage is more, mainly because of the genetics of the eggs. So that's how it translates into that.
Not only the genetics, the genetic makeup might be fine, but the hormonal environment is not able to support this
the
baby.
pregnancy. Yes, that too. So then let us go on to a lot of the other shall we say, commonly associated blood disorders, and we see a lot of them in our hospital. And I think maybe that is because we also treat women who have had 6 and 8 and 9 miscarriages and things like that. So we have a lot of this happening. Some of them are very difficult to treat, and these are. Can you tell us about a little bit about the blood clotting disorders, please?
Yeah, blood clotting disorders in the general population, they're hardly 1 to 2%, and we don't expect general people to know about it. But our infertile population and those ladies with recurrent miscarriages, nearly 10 to 20% of them happen to be APLA, anti-phospholipid antibodies positive. What does this imply, and whom do we exactly look for? If you have had recurrent 2 to 3 first trimester abortions, or a single abortion after 10 weeks of pregnancy without any established cause, or if you have had a previous pregnancy which ended in preterm delivery because of high blood pressure or abruption, you are a candidate who will be suspected to be having this APLA.
Now see, these APLAs, antiphospholipid antibodies. Now, phospholipids are the shall we say,
membrane lining
protein. Yeah, they're present. They're a mixture of lipases as well as proteins that are present in the lining of the blood vessels. So what happens is these antibodies attack these linings, and you can actually see in the small circle that is there, when the blood vessel wall, that is the blood channels carrying the blood, are destroyed, then that results in a higher tendency to clot formation. So what happens is that will clot and will not allow enough blood to, in very, very layman terms, in very, very simple terms, it is a condition where there is clot formation as well as inadequate placentation, inadequate
Attachment of your baby to your
to
womb.
the womb, yeah, and that happens through a medium called the placenta, through which you have all the nutrients coming in and all the waste materials going back to the mother, and that is an area where you have plenty of blood and plenty of blood vessels, etc. So those get damaged and decrease the blood supply and the oxygen and nutrients to the baby. So there are plenty of mechanisms that we're trying to get into. That is like really difficult to explain in a matter of 15 or 20 minutes, but that is something that we would definitely look at. But but then you want to tell them about exactly how we treat, and if you don't treat, what happens? If you treat, what happens?
Okay. So once we are able to pick up that the patient definitely has APLA, the studies have established that without any treatment, the chances that these ladies might carry on to have a successful pregnancy is hardly 10 to 20%. But with treatment, which includes blood thinners like heparin and aspirin, together these two ensure more than 70% success for a pregnancy. And again, we are really happy to treat them and get them a successful outcome.
Yeah, we have a lot of experience in that. One more reason for a recurrent miscarriage could be infections, and you have plenty of infections in the community as well as genital infections. Mainly, we're talking about genital infections. You have gonorrhea, chlamydia, mycoplasma, and tuberculosis is something we should not definitely ignore, because India is a country that is where tuberculosis is endemic. So if it comes to the uterus, it can produce what is called as tubercular endometritis. That means the lining of the womb has the infection, and it is a very tuberculosis is very common in our country.
Yeah,
so
true.
we have fantastic drugs, and so we can definitely treat it, and it can definitely be treated. So we do need to check the person, whoever the lady who's coming to us for tuberculosis. So this will be in our gamut of tests. And of course, the male factor, you have a situation where you are going to have the sperm contains DNA, and DNA, if you imagine, DNA is the structure of a DNA is like a twisted ladder. So a ladder that is spiral, and so if you have breaks in it, you have what is called as DNA fragmentation and DNA damage, and so the sperms can also be a contributory factor to miscarriages.
Yeah, remember the men can also be responsible for all the trouble.
Yeah.
And especially the ones who have excessive alcohol control, poor lifestyle choices, smoking, all this contributes to poor sperm quality.
Yeah, especially smoking. I want to make a note about smoking. So you have patients come in and say, only smoke one a day. So if you're only smoking one a day, why at all smoke it, isn't it? You can actually stop it. So this DNA, this is what it's talking about. Smoking does affect the DNA content in the sperm. So people who are smoking and whose wives are recurrently miscarrying, then that may be a good reason to stop the smoking. Now, this is another very important. We're coming to the second trimester miscarriage. We're still in the causes of. We're talking about how to treat it as well as what could be the causes. So this is the second trimester. So in the mid trimester, that is anywhere between 13 and a half to about 26, 27 weeks. These are some of the causes that we will look at. We will look at APLA, and we will look at cervical insufficiency. So do you want to tell us a little bit about that?
So we have few ladies coming who have successfully carried their pregnancy up to 12 weeks, 14 weeks, 16 weeks, and
that is about 4 months or 5 months,
yeah,
right? Yeah.
And suddenly they have happened to lose the baby without any prior pains, without any indications. Unfortunately, the baby seems to just slip out of their uterus.
Yeah.
Just for some unknown cause, their womb is not able to hold their all normal baby back.
So the thing is that the womb is divided into two parts. It has a body and it has a neck.
Yeah.
So the neck or the mouth of the womb. So the neck or the mouth has to be really tight so that it can hold the pregnancy back. So as the pregnancy starts to increase and the weight of the baby starts to increase, somehow the neck of the womb, which is also called the cervix, does not have the capacity to hold on to that weight. Yeah. So it opens up, and they can have what is called as an extremely painless delivery. That they won't only when it is coming out, they think, oh my God, something is coming out, and then they go to the bathroom, and then there the fetus has come out, which is very, very tragic, because it kind of produces a shock to all the members in the family, and especially the patient, the mother. So there are situations where we can actually treat it. We do look for it. We do a hysteroscopy. We look and see whether the womb is, the neck of the womb is weak or not. And then if it is only the first time that has happened, then we would put what is called as we in our hospital, we put what is called as a Shirokka ligature, which is basically a stitch to reinforce the neck of the womb.
Yeah.
and hold it, help it to, it's like a supporting stitch. Of course, it's not 100% foolproof, but then we have managed to salvage a lot of pregnancies.
Yeah, a lot.
That is one thing. But then if it is repeatedly happening in spite of putting this cervical encirclage or the cervical suture, and it's not able to kind of still hold on to the pregnancy, then there is what is called as a abdominal cerclage, which we will do from the laparoscopic route, and we will put a stitch at a higher level, and that remains inside the womb, and we've had excellent success rates with this. But that's only for a select group of people. It is not for
Yes.
everybody who has one mid-trimester miscarriage, and we leave it in even after the baby is taken out. Unfortunately, one of the things about a cervical encerclage is that you have to have a cesarean section. But after, I've had plenty of patients where they actually say, let it be in, doctor, and then I'll try for the next pregnancy. So they come back after the next pregnancy, or and then only take it out. So it's a very, very good mode of treatment for second trimester pregnancies. And the other reason could also be the shape of the womb. So do tell us about the various shapes that we can find out which do lead to a miscarriage.
Okay, sometimes the triangular shaped cavity of the womb is interrupted by a septum or a fibrous tissue that grows within the uterus.
It's like a wall, right?
Yeah,
That
it's
is
like a wall,
dividing
dividing the uterus
into
into
two halves. Yeah. So if this is seen in a person with a recurrent abortion, then this will have to be cut and be divided, and we unify the uterus and make it into one. But then there are also some people who have what is called as an arcuate shaped uterus, where it's only like a small dip inside.
Yes.
So all arcuate shaped uteruses don't need correction. But only if it is associated with miscarriages,
Yes.
then maybe the recommendation is that you would need to at least have a scan, maybe a 3D scan. 3D
Yeah,
scans can
definitely.
pick it up,
Most
right?
sensitive 3D scan as good as MRIs.
Yeah.
And we routinely do investigate our infertile pregnant population and our recurrent miscarriage population by a 3D,
scan to see if there's any anatomical
Yes.
distortions. Right, so that is a 3D scan.
Yes.
That is on the other side.
Also, in addition, there can be some benign tumors in growth into the womb, into the cavity of the uterus. Also, there is sometimes some fibrous tissues or adhesions that is not letting your baby implant into the uterus.
And that's a very simple procedure. Just go and take it out,
Yes.
and then it's all from down below. There's no cuts on the top. It's all from from the vagina. So that's easy enough. So this is again showing us a septum. Is that correct? And
Yes.
then the two, you can see the two halves, and then the uterus has been divided into that.
Yes, our hysteroscopy procedure.
Yes. And so now we are coming to the realm of unexplained recurrent miscarriages, which is very difficult. You can have you do all these tests for looking for infection, do a 3D scan to rule out any uterine abnormalities, and then you do an APLA testing, and then you do tuberculosis, you do for infections, and then you do everything, and then you still find out that you do a genetic testing and it's still negative. Then that becomes a little frustrating for the couples as well, because everybody wants an answer, but quite often not having an answer is also a good thing, isn't it? If you don't have infection inside the uterus, hey, good,
That is
fantastic.
true.
Yeah.
And after 3 miscarriages, if it is an unexplained miscarriage, there's almost 60 to 80% chances that your next pregnancy might turn out to be normal. We really don't have an explanation for that.
Yeah, so now then we will have to look into immunological factors. Now I just want to say one word about the immunology of pregnancy. I've already said it before. It's a very complicated process where the uterus accepts the baby as its own and shows it to the rest of the body that this baby is my own, this is mine, and so there's nothing foreign about it, although it is foreign, because it has the father's complement of genes and characteristics in it. So then we come to this immunology of pregnancy, which is very, very difficult, and a lot of research is being done. So anything that has to be done should be done under research settings. And in very, very, just 2-3 sentences, can you tell us about this, please?
So our immune system is an amazing system of work where everything is balanced such so that it can identify any problem causing organisms or products that can harm the baby, harm the body. When this foreign baby is implanted into the uterus, there should be a mechanism to sensitize the mother that this baby is not going to cause any harm to her body as such. That happens in all normal pregnancy, and it is a miracle of nature. But unfortunately, in some people, what happens is this delicate balance in the immune system is lost, and usually between 4 to 12 weeks, the mother seems to develop certain killer cells, antibodies that goes on to destroy her own baby.
I just want to make one thing very clear. We're using these terms like killer cells, etc. So we all have natural killer cells. Those are very important for us in our body, that to keep our cells from growing, from dividing uncontrollably, and all those various things. So it has nothing to do with the mother. The mother has nothing to do with it. I mean, it's not her fault. I mean, she's a woman is born like that, or she's deficient of that mechanism, or there may be what is called as HLA sharing between the two partners. So she's unable to mount a response. So it is not, so we're not implicating the woman, but we are trying to kind of find out the cause of immunological.
We're just trying to find by if we are able to find a solution, if we understand the mechanism, maybe in future we will find a solution.
Yeah, so it's not anybody's fault that they are having a miscarriage. It is just that certain immunological conditions that are processes that have to happen to accept a baby are not happening in that particular woman, right? So this is another area which is undergoing a lot of research, where they talk about the HLA mechanism.
HLA is a kind of barcode on each and every cell on your body, and these are screened and recognized by the immune system. Sometimes, if the father and the mother share the similar HLA structure, the immune system seems to get confused as to whether the baby belongs to its own or it's foreign, and it sometimes happen to mount a attack on the baby.
Yes, very well said, because it's a very, very difficult topic to explain to the lay public, and I think Nayya has summed it up very nicely. It is very complicated, and it is also there is only very few treatments for it, and if you do a treatment, it should be in a research setting. So that's what is said internationally. But we have started HLA typing, and we've seen a lot of women who have had miscarriages who do share HLA with their partners, and one of the therapies. Okay, you put up a nice slide about a cheetah. Do you want to explain this then?
Yeah, you can wonder, what if I share similar HLA typing with my partner? What trouble is it going to cause? In fact, even in nature, they have observed that in a group of closely breeding cheetahs, they found that when this HLA is having a close match, these cheetahs turned out to be really susceptible to few infections, and their immune system seemed to be really compromised. Maybe we will end up finding a similar explanation in humans too.
Yeah, so there's a hell of a lot of research that is happening in this field of immunology of pregnancy, and it's very, very exciting. But right now we don't have all the answers. So some of the other problems could be the NK cells, and we really won't go into that. This is leukocyte immunotherapy, which is again something that we do for our patients, and it seems to have been working, and we've been doing it for a very long time, and I'm very comfortable with this procedure, and this is something that we do pretty often. Again, it is related to the HLA, and it is very complex, and it can't be covered within our realm of 15 minutes. And
seems to be really helping with our immunological causes.
Yes. So we are in the process of also trying to kind of do some research on that. But what about the emotional impact? Any pregnancy starts off with a lot of hope in the mother, and when they do start to bleed, they come back with a lot of panic attacks and very, very worried. And it does have an emotional toll. You want to talk about that then?
Yes, even though we happen to put it like a miscarriage is a very common occurrence, it can be devastating for the mother.
Yeah.
She's overcome by a lot of emotions. There is, first of all, there is sadness, there is hopelessness, there is also some amount of frustration, there is anger that she really was careful throughout her pregnancy and why this happened to her. There can be frustration that many of her friends simply seem to be conceiving so easily and happen to be carrying their babies home. What is wrong with her? And also we have to remember that though both the couples go through this emotional trauma, both of them will react differently. The lady has to undergo both the physical and the emotional part of the miscarriage, the pain.
Yeah. And also pregnancy in anybody, especially in our culture, also is a celebration.
Yes.
And when it ends in a miscarriage, it is a real frustration for the couple, who are always looking for answers. But believe me, you don't get answers every time, but there are plenty of ways that one can actually be helped. And one miscarriage doesn't mean anything at all. You are very capable of having another pregnancy and taking it right up to the stage of delivery and carrying a beautiful baby back home. But sometimes if you keep on having miscarriages, then that is the time that we have to intervene.
They do need a specialist care for that.
Yeah. And so we are a 45-year-old hospital now, and we have always specialized in high risk obstetrics and a lot of recurrent miscarriages. I remember a lady who had come from Rajasthan who had 9 miscarriages, and she took her 10th pregnancy home. The baby from her 10th pregnancy went home, and she'd had a mixture of stillbirths, babies dying at 5 months, several miscarriages. And so it was a mixed bag. So not every patient is the same. They don't all miscarry before 12 weeks, nor do they all miscarry only after 12 weeks. There's no rule for that.
Exactly, ma'am. And there is no point in comparing the grief of one lady with the other. A lady who conceives a 6th time after fertility treatment and she's happened to be losing her baby, we really can't compare her pain with anybody else.
Because everyone's pain is individual, and everybody grieves in their own way, and every miscarriage produces pain, and we understand that completely. And
as a society, we should really get sensitized, and we should really be able to support them in whatever way possible.
Yeah, so this is just to sum it up, and you have to kind of get to a place which understands what is happening, is in touch with the latest shall we say happenings in the world, and how we can actually take it forward. And you want to sum it up, Navya?
Yes, in case you have had a recurrent miscarriage, it is important not to have self-blame and to always be hopeful. Just remember that even after 3 to 4 losses, your future pregnancy outcome can be as good as 50 to 60%.
Without too much of intervention.
Without too much intervention, right.
So just keep that positivity up. And go back to your doctors if you're really upset, or if you really want any help. But then you can get pregnant. Just keep that in mind. It is only tweaking a few factors here and there, and we don't say that we salvage all pregnancies, but we have helped enough number of women, I'm sure of that.
Yes.
And we are still in that journey. And I would thank you all for having joined us this time. And if there are any questions, we would be happy to take it. Anything?
Also, we should give credit to these ladies who take home their baby after recurrent
miscarriage. Yes. It's a lot of what shall we say? A lot of shall we say? A lot of resilience that they have to go on and on and on without without actually giving up.
I'm
that's what you
really
need.
inspired by some of them, ma'am.
Yes.
I really
and
it's easy for us to tell about hope, about future, about medicines. It is they who take them, they who face the situation, and we keep them on regular follow-ups. It is not just the first few days of the pregnancy. Even in the second trimester, we call them back for regular scans, and we always monitor the cervical length, they seem to be so compliant. It is really hats off to
Amazing. Yeah,
these
hats
ladies.
off to our patients. So do thank you, like I said, for joining us. Do come back for our next program on fibroids. It's on the 18th of July. And thank you so much from both Dr. Navya and me.
Thank you so much, ma'am.